The following content is for entertainment and educational purposes only. It does not constitute means for diagnosis, healthcare advice, nor treatment. Make use of a qualified healthcare professional for such purposes.
So let's talk a little bit about depressive disorders. First, notice that one of the common characteristics, one of the common diagnoses that we have is MDD, or major depressive disorder. Major depressive disorder is way more common than DID. It's one of the most common diagnoses that we have. Notice that in this specific case, it's also chronic, right? It is long-term. It is persistent. It remains present. Very similar to generalized personality disorder, in which the anxiety is ever present. So is the case of major depressive disorder, but it's persistent feelings of sadness, right? It is persistent feelings of despair. And it's also characterized by not being interested in things that cause you happiness and pleasure in the past. Notice that in a similar fashion, let's try and define other terms that are related to MDD. Anhedonia, it's basically your ability has diminished. You simply don't have pleasure in anything anymore, right? So notice that a person who has MDD, say for example, the person used to enjoy, which is my case, I used to enjoy coin collecting a lot and collecting gold and silver, things like that. And that was a hobby that I've been engaging in since I was 4. And notice that when a person has depression, things that used to cause them pleasure and happiness, they simply just don't have any interest in it anymore, even though it was something that they truly love. So for example, watching sports or reading a book or things that they actually found interesting, or going out or going on a jog. Notice that the person has lost the ability to experience pleasure. The person simply does not have that diminished, it has a diminished interest of experiencing happiness and pleasure. Generally, depression can occur at any age, at any time, right? Since you are a child all the way out to late adulthood. But generally, the average onset for depression is in your 30s, in your early 30s. So generally, it's characterized by that time age, although I need to remind you, it can happen at any time, right? It can occur at any time. It can happen to anybody. So that can include children, adolescents, and adults. Interestingly, in regards to this fashion, it is getting younger, right? The onset of depression is getting younger. We are seeing more suicide attempts, completed suicide and suicide ideation in younger children. My youngest right now is 7. And I highly consider that this kid, had he been a little older, he probably would have completed suicide. Because I have no doubt that this kid had the intent to commit suicide. It is getting younger. Generally, the youngest we used to see was like 11, and now we're seeing 10, 9, 8. We're seeing younger ages. We are seeing younger ages for sure. Notice that about two-thirds of individuals who are indeed diagnosed with MDD will have more than just one episode during their lifetime. So if you have been formally diagnosed with MDD, chances are it's going to happen more than one time. All right, so it's going to happen more frequently. Let's talk about bipolar disorder. So before we continue, major depressive disorder and bipolar disorder are in the category of mood disorders. Remember, the DSM categorizes mental illnesses, so they're both mood disorders. What is bipolar bipolar disorder. Whatever you think bipolar disorder is, I need you to forget about it right now, because most people have no idea of what bipolar disorder is. So whatever you think about it, I need you to forget it, because now we're going to talk about the real definition. It is a mood disorder, just like depression. And notice that bipolar disorder is characterized by both having manic periods and depressed periods. What is a manic period? What is a manic period? I like to call manic the upper. That's what I like to refer to it, the upper. Why is it the upper? When a person is manic, they feel like they can save the world. This is when a person starts having excessive energy, less need for sleep, right? They sleep 4 hours, if that, and they feel super energized. They'll paint the house seemingly for no reason. They'll start buying on Amazon seemingly for no reason. They start taking more risk than you normally would. So for example, the person, instead of spending money for the mortgage or the rent, they're spending this money in a sports car, right? So that's something that wasn't thought after. So notice that it's an upper, right? The person may start engaging in sexual acts that perhaps were not in their best interest. So for example, they start having sex with strangers. They start having sex very risky, right? So for example, cheating. They start doing all of these behaviors that could be putting this person at risk. Gambling, right? Risk-taking behaviors, driving really fast. But notice that the person, when they're in their bipolar, they feel great. There's no distress. Remember, that was one of the key factors for diagnosis, right? Person doesn't feel any distress. They feel great. They finished all their homework. They wrote all their papers over one day. They're feeling great, right? There's nothing wrong with me. But notice that the situation is that now I'm doing risk-taking behaviors that couldn't be putting you at risk. Now, I mentioned that bipolar disorder is also characterized by depressed moods. So notice that you're going to be in your upper, and depression is going to be the downer. Now it's the complete opposite. Losing interest in the things that you were interested in, right? So you used to read a lot, and now you're not reading. Right? So notice that the person will have diminished interest. Notice that you're going to have that elevated mood. Notice that it's going to go up to the point of euphoria, right? You're in the upper, in the big upper. Notice that in regards to bipolar disorder, the individual for bipolar I generally is fully manic. Whenever they get to that upper, is fully manic, right? It's fully elevated. Bipolar II, on the other hand, it's basically very similar to bipolar I, but it's a little bit more mild. It's still upper, it's still an up when compared to the average person, but it's a little less upper and it lasts a shorter time. In regards to symptoms, at a very minimum, we expect to see them every 3 months for the duration of at least a year, right? So you can accurately diagnose someone if we don't have evidence that this has been occurring for at least a year. And at the shortest, every 3 months. So you have 3 months of depression, 3 months of manic, 3 months of depression, 3 months of manic, right? So you expect to see that for at least a year, at the shortest, every 3 months, okay? And next time, we will continue with more of this factor. Now, previously, we did cover a little bit the aspects of bipolar disorder, and I wanted to mention the differences between bipolar I and bipolar II. As a quick reminder, remember that bipolar disorder is characterized by what I like to call the upper, right? So the mood is immensely elevated. So for instance, the person, I like to call it, they think they can save the world. So for example, they study for all of their exams, they write their papers on time, they need very little sleep in order to accomplish their goals. They may start engaging in risk-taking behavior. So for example, maybe they start drinking, driving really fast. doing things that are not necessarily in the best interest. So for example, they start gambling and spending a lot of money when they know they have to pay their rent. They may start engaging in sexually risky behavior. So they might, for example, start flirting or having sex with people that they don't know, which could lead to a dangerous situation. So it is pretty common that when a person is manic, when a person is in that upper stage, notice that the person feels great, right? So when you're talking to a person who is bipolar and you tell them, hey, you seem a little hype, right? You seem a little hype. So they don't see it. They feel great because conversely, the other side of things is instead of the upper, we're going to the really low, right? So for example, that person is going to start experiencing symptoms of depression, right? So isolation, maybe overeating, maybe undereating, sleeping too much or sleeping too little. So notice that now that person is going to the downer. And some people actually report that they like being in their manic state because they can accomplish, I should say, so very much. And we also talked about bipolar II. And bipolar II is similar to bipolar I, but the difference is that their up is not as up, right? It's a little lower, but compared to the average person is still pretty high. And I wanted to show you guys an illustration of such. So of course, we're not going to do any statistics in this specific class because this is an introductory class and it will be outside of the scope of that particular aspect. But nonetheless, I do want to give you an example so you can visually see what I mean when it comes to the differences between bipolar I and bipolar II. Bipolar I, it tends to be more common. So I do want to mention that it is a little bit more common when it comes to prevalence. So imagine that I have, right? Imagine that I have this line, right? Imagine that I have this line. And basically, when we are thinking about normacy, I want you to think that what would be considered normal behavior is basically the behavior in the green, right? So this would be considered the behavior of the green. So this would be the average or the mean person, right? So basically the scores that we would expect from a person normally, not too manic, not too depressed, basically your average individual. So let's look at a person who is bipolar. A person who is bipolar I, notice that what's going to happen is that there's going to be some points that, for example, this here is going to be manic. And under this line, so over this line, we're going to consider this as manic. And then under this line, we're going to consider depression, right? So we're going to consider depression. So notice that the average person would hover around both aspects. What happens with a person who's bipolar I? Notice that generally we expect to see the symptoms, right, within a cycle, right? So if your boyfriend, girlfriend, parents, they were angry this morning and then in the afternoon they seem happy, they're not bipolar, they're simply moody, right? That could be a characteristic of another mental illness. But notice that the cycle, at a very minimum, we have to observe this cycle within 3 months for at least a year, right? Otherwise, it cannot be accurately diagnosed. So we have a bipolar I person, and notice that above this line, we're starting to consider that this person is manic. So a person who is bipolar I will be extremely elevated. So we start seeing, say, for example, risk-taking behavior. We start seeing sexually risky behavior, drinking and driving really fast, finishing all their homework in one day. So notice that the person will report that they are doing super great. But notice that as they reach that line, and this here would be considered about 3 months, right, of that upper, notice that the next 3 months, the person is going to hit a very low. So for example, now they're depressed. Now they are under eating, they feel loneliness, perhaps suicidal ideation. And notice that this again would be another cycle, right? Another cycle of the 3 months. So this here would also be about 3 months. And I need to see at least 4 of these, cycle of up and a cycle of down and a cycle of up and a cycle of down. Now this would be a bipolar I. A bipolar II is very similar, but their up is not as up. So notice that a person who's bipolar I is still up, the behavior is still up, but that is what we call hypomanic, right? So it's not a really high aspect of being manic, but rather this person here has a much shorter and not as clinically active. So notice that this person for bipolar I, their manic was super manic, but for a person who was bipolar II, their manic is not as noticeable. Notice that it's still manic because compared to the average person, it's still pretty up. Their behavior is still considered pretty upper. But notice that that person's upper is still lower compared to the bipolar I. It's still hypomanic, but it's still high enough that it wouldn't be considered average. It wouldn't necessarily be considered average. And the same happens with their depression. Notice that when the bipolar II individual reaches their down, may not necessarily be the same. Notice that compared with the same average individual is still depressive behavior, but notice that the main characteristic that I am trying to illustrate is that for the bipolar II, the behavior is considered hypomanic. So this would be considered hypomanic. So that is one of the main differences that I wanted to illustrate between bipolar I and bipolar II. Another difference that I wanted to illustrate is that the periods tend to be shorter. So if you notice, this period here was actually shorter, and this period here was actually shorter, right? It didn't have so much of an amplitude. So notice that the amplitude for bipolar II is lower, and notice that the amplitude for bipolar II compared to the depression of bipolar I was also significant because it's not the same as an average person, but it is not as significant in the sense that it's a shorter span. So any questions about that? Yes, sir. I'm sorry.
How does lithium?
So one of the treatments that we do provide for individuals who have bipolar disorder is by providing medication such as lithium. Notice that for bipolar disorder, we're actually going to cover some of the etiology for bipolar disorder. Notice that people who are bipolar do have a chemical imbalance. So what it does is that it provides some sort of chemical balance so that the person hovers within normacy. So it decreases the chances of that individual suffering from a manic episode, whether it be fully manic or hypomanic, and vice versa. So for example, a depressive symptom or a subdepressive symptom. So basically the way that lithium works is balancing your chemical imbalance. Yes, sir.
So you said most people do still cycle
Right.
a bit. So what is the normal person's cycle, just to get an idea of what the difference is?
So most people will go through life circumstances where they would feel on top of the world, right? And they may also feel sad. The difference is that an individual who is average, person who is normal, they will go through stages in which they are in the sense of the lower. But the difference is that that would be considered sadness, right? It's a form of average reaction. So that is the main difference. We would expect that the average person will become sad, but won't become depressed. And the same goes for the expectation of the average person. So for example, an average person due to life circumstances, for example, maybe they're getting married, maybe they're graduating, right? So notice that they will have that upper, but it's not going to be as high. We would find that through life experiences. For example, well, of course you feel on top of the world, you're graduating, right? So that's an expectation, but feeling on top of the world apparently for no reason, then we need to start observing, are you taking any risk-taking behavior? So that would be the first thing that I would look into, would be, has your speech changed? Because that's another thing. Bipolar people, their speech tends to change pretty significantly too. They go 1,000,000 miles per hour. They can't repeat sentences. So that's another characteristic. Yes, sir.
Is it the same as bipolar depression, or is that separate?
We used to call it manic depression, by the way. So we don't refer to bipolar disorder anymore as manic depression. Now we refer to it as bipolar disorder, just like we don't refer to Asperger's, now it's autism, just like we don't say mental retardation, now we say learning disability. So we used to refer to this as manic depression, and it is not the term that we utilize anymore. It's considered bipolar or bipolar II.
I was talking about bipolar depression.
Any more questions? Yes, ma'am.
Okay, when you say average, are you talking about the hypomanic?
When I say average, I mean every single one of you guys, people who are not a clinical sample, right? People who are just average Joes and Janes, right? So not a person that I would expect that would be suffering from a mental illness. So like you or me, just average people. I say that with a little caveat because every single person will suffer from a mental illness at least once in their lifetime. So every single person you've ever known has had a mental illness. It's just that most of the time they haven't been diagnosed. But what I mean by average is our typical normal response that we would expect, right? So for example, if my dog dies, well, the average person will be sad about it. So if I get sad about it, that's a typical response. But if I stop eating and it's been over a year and I'm still grieving this process, well, now we're dealing with grief because that wouldn't be necessarily the average common response. So that's what I mean by average. Yes, sir.
I think just more sort of expanding or clarifying on the my previous question is basically, I'm more wondering, does a normal person have like still like a regular cycle?
Right.
Like, or is it more sporadic and like just dependent on environment, or is it like cycles of being like even just like more optimistic or pessimistic or whatever, even the course of a day?
I would argue it has to do an awful lot with your environment and also with your chemical, just like your chemical variations in your body, what we would expect normally. So most people, a lot of people feel sad in the morning, by the way. Most people feel sad in the morning. So I am sorry that you take this class so early in the morning. The expectation is that you are sad right now. So I'm trying to brighten your day, right? So the average person is sad during the morning, or at least unhappy, unhappy or angry. So notice that that is the expectation. So it will change during the day. But if you're feeling super depressed, well, that's not the common expectation. So persons will cycle, right, across either their lifespan or because of life expectations or life events. But when it's comparatively different from the average, that's when we start thinking about, are you crossing that clinical line, right? Are you above that clinical line? Are you subclinical? So that's when we start looking into, okay, this looks more like a mental illness.
So it doesn't, basically, it's not as regular as, for example, bipolar, where it's like defined like 3 months
Right.
a year, you said.
Any more questions? Yes, sir.
Isn't there another form that's like related to like bipolar? It's more moderate than B2. It's cyclothymia.
So we have other forms of mood disorders, and it's good that you bring that up. So we do have other mood disorders. So for example, we can be bipolar with psychotic symptoms. So imagine that the person is so manic that they start hallucinating, right? So we can have, for example, bipolar with psychotic symptoms. We can have a person who's bipolar, and they start presenting more depressive symptoms. So for example, then we start seeing a person who does show mania, but their mania, they don't show as much mania, but they still show way more depression that they show mania. It's still above the average because it will still be more than clinical, but notice that their depression would be greater when compared to their manic. So you are correct. There's other forms of bipolar. These are just the more common diagnoses that we have for bipolar. Many individuals suffer from bipolar disorder. I wouldn't say is super common. It is not atypical. Let's say that it's not atypical. There's many celebrities who suffer from it. Mariah Carey suffers from bipolar disorder. Demi Lovato suffers from bipolar disorder. So it's actually relatively, I wouldn't say it's super rare, but it is one of the more common aspects of mental illnesses. So that's one of the reasons why we discuss it here. Notice that you don't necessarily have to have a mental illness to complete suicide, right? To complete suicide, however, it's more likely. It's more likely that if an individual completes suicide, notice that we can find some form of an aspect of suicide. Individuals who are bipolar are at a higher risk of committing suicide. Individuals who have anorexia nervosa are also at a really high risk. Individuals who are identifying as non-binary or transgender are 3 times more likely to commit suicide. So yes, having a diagnosis could also increase the chances. Yes, sir. Good deal. So when we are thinking about, as the question that she mentioned earlier, we talked about lithium and potential causes for bipolar disorder. So let's look at some of the etiology for bipolar disorder. Notice that if you have family members who do suffer from bipolar disorder, that could increase the chances for predisposition. And again, when you see the word predisposition, I don't want you to think that, yes, absolutely, I am going to have this disorder. But it does certainly contribute with the possibility that you can develop this mental illness. To answer the question, what's your last name, sir? Weaver. To answer the question that Dr. Weaver was mentioning earlier, notice that we may have issues with our neurochemicals, right? So a chemical imbalances. Notice that statistically, we do have a correlation. We do have a correlation between mood disorders, so depression, hypomania, bipolar. We do have a correlation between the abnormal levels that we would expect between neurotransmitters and mood disorders. Again, the correlation is not a causation. Therefore, we do have a correlation. We can't strictly say that that is specifically the cause, but it sure does have a link. Notice that something else that could occur is hormonal factors. Notice that hormonal changes, right? So not necessarily neurotransmitters, but hormones and changes in hormones can contribute to aspects of depression. Let's look into other potential etiology when it comes to mood disorders. Notice that we also have cognitive factors. And again, every time you see cognitive, I want you to consider way of thinking, right? Your thoughts, the way that you think. Notice that individuals that are depressed generally are geared towards negative thinking, right? So for example, the thoughts that the individual may have are generally geared towards sadness already. So for instance, if you suffer from depression, you may say, well, I'm always alone. I'm always lonely. Nobody wants to talk to me. But then we go to therapy and I ask you, okay, I want you to keep tabs for 1 week about how many text messages you receive, WhatsApp, Twitter, Instagram. I want you to keep tabs on that, how many phone calls you get, how many DMs you get, and notice that when the person comes back, you're gonna be like, oh, I have 50 messages. That doesn't really sound like a lonely person, does it? So we try to confront the irrational thought. We try to face the irrational idea. Notice that people who tend to be pessimistic, notice that the person does not evaluate the alternative aspects of their surrounding. So for example, class is going to suck today. I don't want to go to class. This is going to be an awful class. I don't like the way Dr. Shar teaches. Notice that you are already setting yourself for failure, because now people who think like that are generally more vulnerable to the aspects of depression. And the last thing that people generally think of, right, whenever they are depressed, generally, which is pretty rare, most people do the opposite, right? But people who are usually focused on whenever something goes wrong, it's because of me. It's because of personal flaws and not necessarily because of situational factors. Yes, sir.
Isn't attributing your own failure to your own fault, isn't that a healthy thing to do? Like, isn't it healthy to like look at what you can do to fix things rather than say it's everyone else's fault?
And you're correct. We like to have something that we call locus of control, which is we focus on what is it that I cannot control, what is it what I can control. The difference with a depressive person is instead of looking at responsibility, they look at fault. So for example, it's very different for me to say, I'm going to fail the exam on Friday because I didn't study well enough. It's very different to say that I'm going to fail the exam on Friday because I'm stupid. So notice that they're both implying a sense of self, right? They're both implying a sense of responsibility. But notice that one implies responsibility and the other one involves guilt. The other one involves fault. I'm so stupid that that's why I can pass Dr. Shar's exam, which is inherently not true. You can study. The exam is passable because other people can't pass. You're not different than other people. So notice that a person who's depressed, instead of using the sense of responsibility, know what I need to do. I need to schedule an appointment and I need to read the slides or watch the videos on YouTube or talk to Dr. Shar. Notice that instead of focusing on that aspect, a person who is depressed may start accepting guilt because of a personal deficiency, right? I'm stupid. I'm never going to be smart enough. I'm not smart enough for college. I don't understand psychology. I'm more of an analytical person. So those could be some of the aspects that could lead to depression. Now, notice that we can also have aspects of interpersonal roots. Notice that in this particular aspect, notice that social difficulties may lead a person into depression. So the circumstances that you have been filled with. Notice that there's also an aspect of stress. Notice that there is a relationship. There is a relationship between major depression and bipolar disorders as an onset for stress. So generally, when we ask individuals, when did you start noticing that you were depressed? That's one of the first questions that we ask, by the way. When did you start noticing this? A month ago, a year ago, since I was 7, right? And notice what we can do is that the individual can identify generally a source of stress that could have been the onset of their depression or bipolar disorder. So any questions about that?